So a wonderful data shown by Dr. Priyanshu about the second line usage of anti-PD-1 or checkpoint inhibitor, which was actually the first checkpoint inhibitor to be seen. And now we go on to a PDL1 inhibitor, and atezolizumab or Tecentriq is, I think, an easier way to pronounce it. And we are going to see three trials: IMPOWER 110, 130, and 150, addressing three different issues and its role mainly in the first line. We'll see. So my presentation involves disease background. I won't take it in detail, evolving landscape, just one slide, and then I'll straight away go down to the agenda of IMPOWER 110, 130, and 150 study. I like this slide a lot. NSCLC, slower growing tumor, I can say, as compared to SCLC, since now SCLC is also having immunotherapy along with chemotherapy. Accounts for 80 to 85% of all lung cancers. 15% of patients are never smoker. Median age of 70 years, typically present with cough, chest pain, dyspnea. In India, it's a bit younger. Metastasis occur later in the disease process. 55% of patients have distant disease. It was shown by Priyanshu. Targeted agents have improved the survival rates. Yes, patients who receive targeted therapy, they have much longer survival, or who have identifiable and targetable driver mutations, they have much better survival. But what about for those who don't have any driving mutations? So this was the evolution. I've seen this evolution during my oncology career, and yes, initially we used to fight for this chemotherapy for this particular histology and this chemotherapy for that particular histology, and then came anti-angiogenics, and somehow bevacizumab made inroads into the chemotherapy regime, followed by maintenance, and then finally pemetrexed in adeno, and maintenance pemetrexed led to improvement in survival in the first line. And then came the era of targeted agents. Initially, the actual targets were not really identified. We used to see EGFR amplifications at that time, but Jeftinib, was still considered a wonder drug, and the effect of Jeftinib in some patients was considered equivalent to Lazarus phenomena. Lazarus means it was magical. And then when the exact mutations were identified, first in EGFR, then in ALK, then in ROS, and now there are so many targetable mutations we have, and equally we have the drugs to target them. But still a larger chunk of non-small cell lung cancers don't have an identifiable targetable mutation or an identifiable target, or which are, we can also say, wild type non-small cell lung cancers. And this was what I was talking about. The ones who have a targeted therapy available, they fare much better as compared to non-targeted cytotoxic therapy, and the hazard ratios are in the range of 0.47. So we will be talking about these three trials. IMPOWER 110 is about whether atezolizumab monotherapy a better agent than chemotherapy in PDL1 selected chemotherapy naive patients. So first line, and this will be the comparator arm, will be PEM-based chemotherapy in adeno, and gem-based chemotherapy in squamous. IMPOWER 130 will be looking into whether if we spare steroids, that is, if we use nab-pacli instead of pacli-carb combination, whether this leads to improvement in survival. IAM Power 150 was an interesting trial. There were some very interesting outcomes to be looked into, especially as far as the targeted therapy is concerned. So arm A was atezo with carbopac, arm B was atezo, carbopac, bev, and arm C was actually carbopac and bev only. So was there an additional benefit of adding atezolizumab to carbopac or carbopac bev was seen in this particular study. So first, the monotherapy one, atezolizumab monotherapy compared with platinum agents or platinum-based chemotherapy. So this was the trial, phase 3 trial, PD-L1 selected chemotherapy naive, and stratification factors were sex, performance status, histology, and PD-L1 by IHC. Can you hear me?
Yes, sir.
Hello.
Yes, sir. We can hear you.
Yeah.
We can hear you.
Yeah. So the primary endpoint was overall survival in wild type, as I said, wild type population, excluding patients with EGFR ALK mutations. And key secondary endpoints were PFS, ORR, and duration of response as per RECIST. The randomization was 1:1, and this was the result. In TC3 or IC3, TC3 means more than 50% of tumor cells expressing PDL1, and IC3 means more than 10% of immune cells expressing PDL1. So in those, they were the chunk of patients were around 107 and 98 in both the arms, and the prevalence of TC2 and IC2-3 was that TC2 means more than 5% of TC or IC. I think by now you will be clear what is TC1, 2, and 3. So equal number of population. That means as far as the prevalence of PDL1 expression is concerned, both the arms are balanced. Both the arms were balanced as far as the age, less than 65, sex, white and Asian population, never smoker, non-squamous histology, and performance status is concerned. So the primary endpoint of OS in PDL1 high subgroup was met. As you can see, 6-month OS was 76.3%, and 12-month OS was 64.9% against 50.6%, and the median OS was 20.2 months. The hazard ratio was 0.59, and all the subgroups benefited, and strangely, only the never used tobacco or never smoker didn't actually benefit. The chemotherapy arm really did well in that. Other than that, most of the subgroup benefited. So this was one thing. And the subsequent therapies, obviously the arm A had atezo as first line, therefore the subsequent immunotherapy usage was more in the chemotherapy arm, and other than that, rest of the therapies like chemotherapy or targeted therapy were nearly equal. PFS was also meaningfully better, and this was shown in this particular graph. And if we compare the response rates in TC3 or IC3 population, in arm A, the overall response was around 38.3%, out of which minimal uh, uh, of them achieved CR also, and so was in arm B, but overall response rate was 28.6%. Median duration of response was not evaluable in arm A, and it was 5.8 months in arm B for TC2, 3, and for TC1, 2, 3. Again, median duration response was not evaluable, and it was 5.7 months in all the patients. The side effect profile, obviously, with atezolizumab, the side effect profiles were much better. Grade 3 for adverse events were lesser. Adverse events leading to withdrawal of treatment were also quite less, 6.3 compared to 16.3%. But obviously, the grade 3 for immune-mediated adverse events were more as compared to chemotherapy. And so as you can see in this particular graph, very clearly, these upper all side effects are more in chemotherapy arm, and the lower one were more frequent in the immunotherapy arm. So atezolizumab represent a promising first-line treatment option. PD-L1 IMpower 110 was a positive study, in which, especially in TC3 and IC3 population, really benefited with a hazard ratio of 0.59, and the safety profile was consistent with prior observation. It had a favorable safety profile with chemotherapy, and the safety data were consistent with those from pooled atezolizumab. And patients treated with sorry, actually one of the lines are missing. Anyways, so just for the information sakes, I think most of the panelists and people would be knowing that only 3 immunotherapy agents are approved as a single agent in first line. Atezolizumab is one of them, and the other 2 are pembrolizumab and semipilumab. So we are going to discuss IMpower 150 first, and then we'll go for IMpower 130. So it was a phase 3 study of atezolizumab plus chemotherapy and Bev in first-line advanced non-squamous NSCLC. So in this, the primary motto was to see whether addition of atezolizumab added to chemotherapy Bev combination, and also the other question was whether there was a benefit in replacing Bev with atezolizumab. So the first arm was the replacement arm, and the second arm was all the 4 agents together, and the third arm was the conventional standard arm, carbo, pacli, and Bev. And in the first arm, the maintenance was given with atezolizumab, and in the arm B, the maintenance was with the atezo plus Bev, and the arm C, the usual bevacizumab maintenance. So the co-primary endpoints were investigator-assessed PFS and OSS in intent to treat wild-type population. These were the stratification factors: sex, PD-L1, and importantly, liver metastasis. So they were the important stratification factors. What was the logic of combining all these agents? It was Bev inhibits VEGF-mediated suppression of dendritic cell maturation, enabling efficient priming and activation of T cell responses. Bevacizumab normalizes the tumor vasculature, resulting in much more infiltration of T cell into tumor cell. BEV decreases activity of and derived suppressors, myeloid-derived stem cells and regulatory cells, which are immune inhibitory and enables reprogramming of tumor microenvironment. And chemotherapy as such leads to release of various tumor antigen as a result of cell death. So these were the logic, these were the idea behind combination of all these agents. And the baseline characteristics were well balanced in all the three arms, and 14% of patients had liver metastasis at baselines, which are a stratification factor, and 10% of patients had EGFR mutations, and all the three arms were balanced in this. And PDL1 expression also was balanced. TC0 and IC0 was also there, around 50% of patient, and rest 50% had at least more than 1% of TC or IC PDL1 expression. So first, the comparator of addition of atezo with the arm containing only BEV. So atezo plus BEV, you can see the landmark OS difference: 12 months 67% versus 61, 18 months. So there was a 10% or more than 10% difference in all the three this thing, and the median survival was around 19.5 months. This was about after about median follow-up of 39.8 months. So the improvement in median OS was meaningful, around 4.5 months, and a higher proportion of patients responded to treatment with BEV atezo in combination with chemo. As you can see in arm B, the response rate, objective response rate was maximum. Strangely, arm A and arm C had near similar response rates. In PDL1 high, obviously the arm A and arm B had much better responses compared to compared to arm C, which didn't have any immunotherapy agent. In PDL1 low, also the arm B had a better response. Arm A and arm C were nearly.
My apologies, sir. You are left with just 3 minutes to conclude your presentation.
Okay. And in no expression of PDL1 and DC0, IC0, again arm B fared better. And this is the similar thing we see, and look at the hazard ratio in PDL1 high and hazard ratio in PDL1 low. In PDL1 negative also the hazard ratio was 0.82. So the interesting thing was when EGFR mutated were studied after taking EGFR TKI, so progressing on EGFR TKI. So even they showed a better this thing, and hazard ratio was strangely 0.59. So this was the first trial which really showed that immunotherapy have benefit in patients having a driver mutation. Otherwise, we don't use immunotherapy in EGFR or ALK or driver target the patients in which targeted therapies are available. We don't use these agents. So yes, again, the arm B versus arm C hazard ratio was 0.60 with sensitizing EGFR mutation. So again, the response rates were also better. So I'll just rush through. Strangely, liver metastasis thing really benefited with the combination of atezo-bev and platinum-based chemotherapy compared to arm C. I don't know, in a similar fashion, atezo-bev really affects the HCC patients also, but I don't know. But yes, chemotherapy with Bev and Atezo combination had a very good impact on liver metastasis. And as you can see in these particular graph, but for arm A and arm C, if you compare alone Atezo and Bev, they didn't have any effect. This was the same thing observed in EGFR mutant this thing. So I'll just rush through the summary. Again, patient with bulky disease, with high disease burden and low disease burden, both the subsets actually benefited with the addition of atezolizumab to bevacizumab. So the conclusions were it was a positive study in first line with statistically significant and clinically meaningful improvement in both co-primary endpoint of OS and PFS for for ABCP versus BCP. Clinical benefit was observed in key subgroups of patients with EGFRL genomic alteration and liver metastasis in baseline with the addition of all four agents, means doublet chemotherapy and Bev and Atezo. Atezo in combination with chemotherapy plus Bev is well tolerated and safety profile is consistent with known safety risks. Additional patient characteristics beyond PD-L1 expression may be considered when making chemoimmunotherapy treatment decisions for non-squamous lung cancer. So these are again the same conclusions being repeated here in the summary. So let's come to IMPOWER 130, in which we had the usage of NAB-PACLI instead of PACLI in combination with carbo. So the aim was to reduce the usage of steroids, and the goal of CIT was to create a more favorable environment to maximize potential of immune system to eliminate cancer. So to achieve this aim, there was the usage of NAB-PACLI, and arm A was chemotherapy with Atezo and with Atezo maintenance, and arm B was chemotherapy followed by switch maintenance to pemetrexed. And the interesting thing was, despite the protocol amendment, 41% of patients in the control arm crossed over to atezolizumab. Despite all this, the co-primary endpoint was investigator-assessed PFS, and secondary endpoints were investigator-assessed PFS and OS in intent-to-treat population. Baseline characteristics were similar, and so were PD-L1 tumor expression. They were similar in both the arms. And these were the results. 12-month PFS was in 29, about a double percentage of patient compared to chemotherapy, and median PFS was 7 months. Hazard ratio of OS, median OS was 18.6 months as compared to 13.9 months, and the hazard ratio was around 0.79. All subsets really had a benefit, and liver met at enrollment, actually there was not much of a benefit. Investigator assessed PFS and OS. The OS was not, this was about the mutated subtype, EGFRL mutated. So you need 4 agents or chemotherapy plus atezo-bev combination for EGFRL mutated. And a higher proportion of patients have a complete or partial response in the experimental arm compared to the control arm. So treatment-related adverse effects were also more, and because there was an additive effect of 3 drugs compared to the chemotherapy arm. So the conclusions were IMPOWER 130 was a positive phase 3 study in first line, providing an alternative to chemoimmunotherapy plus chemotherapy regime, checkpoint inhibitor therapy plus chemotherapy regimen for patients with chemotherapy naive NSCLC. IAM Power 30 demonstrates statistically significant and clinically relevant OS benefit, and it demonstrated a PFS and a higher ORR. And OS and PFS benefit was observed across three clinical subgroups, and atezo plus chemotherapy had a safety profile consistent with adverse events associated with single agent therapy. So the thing is, all these three trials were positive trials. We really have to choose which patients require more number of agents and which patients we can do away with just addition of atezo and chemotherapy, and which patients we can give single agent atezolizumab. So this is left to us to identify the right patients for this particular agents, which is leading to improvement in survival, and not only in not only in wild type, that is patients not having any driver mutations, but also in EGFR mutant when they progress on targeted therapy. If someone can afford and is in a performance status to receive this particular regime, you can use it. Thank you.
Thank you, sir. Thank you so much for this elaborative presentation. Sir, I have one question. So, what is your experience of ABCP regimen, and what dose of BEV do you use, sir, in this regimen? I mean, is it 15 according to protocol, or?
Yeah, we do sometimes alter the dose, maybe 10 mg per kg of BEV. Sometimes have to use, and but overall, I mean, not much of a difficulty. I have just used it in one patient. Let me be very frank about it. And just yes, BEV dosage has to be reduced. Nothing much has to be was required to be done. It was a manageable protocol, and the patient was not so young also in that case.